Thanks for messaging, Bhargavi. I was going on speaking actually. I don't know, past 2-3 minutes I've been already speaking. I didn't see it was in mute. Right. Okay, let's restart. Not a problem. Thanks for messaging. Okay, let's restart. A very good evening to all of you. Myself, Dr. Ramyasri, I teach obstetrics and gynecology. So in today's class, we will be discussing oncology, a very important. As many as possible, I'll be trying to give you mnemonics for you to have a better memorization of this topic. Okay, so I'll first start with a basic match the correct this one, and then probably this 1 hour let's attribute to the cervical cancer. Cervical cancer is the most important topic, and let me contribute maximum in making it as simple as possible for all of you. Okay, right. So dermoid cyst immature teratoma is absolutely wrong because dermoid cyst is mature teratoma. It's a benign germ cell ovarian tumor and it is a mature teratoma. Right? Germ cell, endodermal sinus tumor, germ cell tumor, endodermal sinus tumor is correct. Germ cell tumor, one of the germ cell tumor is endodermal sinus tumor, so that is correct. Diethyl stelbestrol causing vaginal squamous cell carcinoma in the offspring is wrong, right? Because diethyl stelbestrol causes vaginal adenocarcinoma in the offspring. Vaginal adenocarcinoma in the offspring. HPV 18 causing adenocarcinoma of the cervix is appropriate. So in this, let's speak few important points pertaining to this topic, okay? HPV 16 is most commonly associated with CS cervix. HPV 16 is most commonly associated with CS cervix. HPV 18 is associated with adenocarcinoma of the cervix. HPV 6 and 11 causes genital warts. HPV 31 and 33 causes CIN, are associated with CIN. HPV 18 is very specific to adenocarcinoma of cervix. That's why here HPV 18 adenocarcinoma of the cervix was appropriate statement, right? And dermoid cyst is a mature teratoma. What are all the germ cell ovarian tumors which you know? The different germ cell ovarian tumors which we have are dermoid cyst, so germ cell ovarian tumors account only for 5 to 7% of ovarian tumors. Germ cell ovarian tumors account only for 5 to 7% of ovarian tumors. And this germ cell ovarian tumors are usually seen in young people. So that is pre-pubertal. So around 15 to 20 years, but they can be present before 15 years also. By God's grace, most of the germ cell ovarian tumors are benign. Whenever I tell benign, they're usually unilateral. So the different germ cell ovarian tumors which we have are dermoid cyst, which is the most common germ cell ovarian tumor. So the single liners which we have associated with dermoid cyst are, it is the most common germ cell ovarian tumor. It is the most common ovarian tumor in young girls. It is the most common ovarian tumor in pregnancy, and it is the most common benign germ cell ovarian tumor. All these are single liners pertaining to the dermoid cyst. So dermoid cyst is the most common germ cell ovarian tumor. It is the most common ovarian tumor in young girls. It is the most common ovarian tumor in pregnancy, and it is the most common germ cell ovarian tumor. It's benign, and it is the what is very characteristic of dermoid cyst is it arises from all three germ cell layers. So there are structures of all three germ cell layers present in the dermoid cyst. So they have endoderm, ectoderm, and mesoderm. So there will be teeth, sebaceous material, hair, and sometimes you can also see a protuberance, which we call it as Rokitansky protuberance. What is the management of dermoid cyst? The management of dermoid cyst is, as it is benign and usually unilateral, you can just do cystectomy. You don't remove the ovary, leave the ovary behind. You just have to do cystectomy. Next, dysgerminoma. The single liners pertaining to dysgerminoma is 10% bilateral. It is most radiosensitive ovarian tumor. It is the most sensitive, most radiosensitive ovarian tumor, right? And it is the ovarian tumor which arises in what type of gonads? It is the ovarian tumor which arises in what type of gonads? It is an ovarian tumor which arises in dysgenetic gonads, like your streak testes, streak ovaries, AISK, dysgenetic gonad. So it is a tumor which arises in the dysgenetic gonads. What are the tumor markers for dysgerminoma? The tumor markers for dysgerminoma are, anybody can answer, what are the tumor markers for dysgerminoma? The tumor markers for dysgerminoma are LDH and alkaline phosphatase. LDH and alkaline phosphatase. And on cut section in dysgerminoma, you're going to see large polygonal cells with lymphocytic infiltration and fibrous tissue. Okay. And what is the treatment? I'll speak later once I finish the classification. So after dysgerminoma, what are the other germ cell ovarian tumors we have? The other germ cell ovarian tumors which we have are endodermal sinus tumor, it's also called yolk sac tumor. The single liners pertaining to endodermal sinus tumor or yolk sac tumor is it is rapidly growing germ cell ovarian tumor. It has comparatively little bad prognosis compared to other germ cell ovarian tumors. And the tumor marker is alpha fetoprotein. Whenever you have yolk sac, you will have more production of alpha fetoprotein. And on cut section, you will see Schiller dual bodies. Cut section, you will see Schiller dual bodies. Okay. Next, embryonal cell carcinoma. We also have choriocarcinoma, non-gestational choriocarcinoma. The tumor marker for non-gestational choriocarcinoma is HCG. And you also have immature teratoma. Immature teratoma is associated with, it is the most common malignant germ cell ovarian tumor. Earlier, the most common malignant germ cell ovarian tumor was, dysgerminoma, but now the most common malignant germ cell ovarian tumor is immature teratoma. Immature teratoma is associated with glial tissues, neuronal components. Okay, so this is regarding the germ cell ovarian tumors. Germ cell ovarian tumors, on the whole, you can remember the treatment as, so usually they are, you always stage the ovarian tumors by staging laparotomy. So you will first do staging laparotomy. Most of the time they are unilateral. So as they are unilateral, you will do unilateral salpingo-oophorectomy. Followed by, we'll give 4 to 6 cycles of BEP chemotherapy. That is bleomycin, etoposide, and cisplatin. So this is about the first one, that is the germ cell ovarian tumors. I also have some of the questions pertaining to the germ cell ovarian tumors now. So these questions, all of you should answer fatafat and correct, okay? A 19-year-old girl is referred to the gynecology clinic with a scan report of bilateral ovarian mass. An MRI scan confirms a bilateral solid ovarian tumor. The blood test results show an increase in the lactate dehydrogenase and placental alkaline phosphatase. So it's a young girl, prepubertal, 19-year-old. So I'm suspecting probably it is a germ cell ovarian tumor which they are speaking about. So it has a bilateral solid ovarian tumor. Okay. Blood tests show an increase in LDH and placental alkaline phosphatase. So that itself gives you a clue that what are we answering about, right? She's referred to the oncology center for further management, following which she undergoes staging for ovarian cancer and bilateral oophorectomy. Her final histology shows marked lymphocytic infiltration in the stroma surrounding the tumor cells. What is the diagnosis? Benign teratoma, choriocarcinoma, dysgerminoma, endodermal sinus tumor. So what is the diagnosis here? So as there is it is having LDH and placental alkaline phosphatase raised, and there is lymphocytic infiltration in the stroma with surrounding the tumor cells. The diagnosis is nothing but the dysgerminoma. So that's the reason why I spoke about the tumor markers and the histology. Next. A 20-year-old woman presents to the emergency department with abdominal distension and pain. Clinical examination reveals a palpable abdominopelvic mass, and an ultrasound scan shows a unilateral solid ovarian mass on the right side. Her tumor markers, alpha fetoprotein was 300 and CA125 was 45. She was then referred to the Gynecology Oncology Center for further management. She had imaging in the form of MRI and CT scans and underwent staging laparotomy with right-sided oophorectomy. The histology revealed a Schiller dual bodies, increase in the alpha fetoprotein and Schiller dual bodies. What is your answer? So when you have increase in the Schiller dual bodies and increase in the alpha fetoprotein, it is pretty clear that we are dealing with endodermal sinus tumor. So this is how they can give you the question. This is how they can give you the questions. So you should be, although how much ever the length of the question can change, you have to be careful with the history. History is one of the very, very important. And in the history, you have to see what are they asking about the tumor markers and histopathological examination. They carry a lot of weightage. And based on the history and tumor markers, you can answer accordingly, right? Next question. 18-year-old girl presents to her general practitioner with distension of the abdomen. Ultrasound scan reveals a unilateral solid cystic mass on the left side. MRI scan confirms that ovarian tumor is confined to the left ovary and the right ovary looks normal. However, her tumor markers, beta HCG and alpha fetoprotein are normal. She is then referred to the Gynecology Oncology Center for further management, following which she undergoes staging laparotomy and left-sided oophorectomy. One of the components of histology shows elements of glial tissue. See here, this patient tumor markers are normal, but on cut section, you are on the histology, you are having elements of glial tissue. So based on the presence of elements of glial tissue, you have to answer this question. So the options which we have here are benign teratoma, choriocarcinoma, dysgerminoma, immature teratoma. Yes, very good, excellent. So this is as there was a presence of glial tissue. So your answer for this will be immature teratoma. Immature teratoma. So 90% of the ovarian tumors arises from the epithelial. So the ovarian tumor commonly arises from, your best answer should go for surface epithelium. Your ovarian tumors commonly arise from should go for surface epithelium. Okay. Right. Now, as I told you, I'll be discussing more about the cervical cancer. So let's shift to the questions of the cervical cancer. Right. So what are the predisposing factors for CS cervix? What are the predisposing factors for CS cervix? Multiple sex partners, genital warts, HPV 16 and 18, virginity, late menarche. So more than one of the predisposing factor here is going to contribute for CS cervix. So multiple sexual partners is one of the correct answer. Genital warts, yes, genital warts is associated with CS cervix. HPV 16 and 18 is also associated with CS cervix. So the causes for or risk factors for CS cervix and VIN are young age at the first intercourse, multiple sexual partners, cigarette smoking, race, high parity, low socioeconomic status, human papilloma virus infection, HIV, and immunosuppression. So all these contribute for risk factors for CS cervix and CIN. So we have young age at the first intercourse, multiple sexual partners, cigarette smoking, race, high parity, low socioeconomic status, human papilloma virus, HIV, and immunosuppression. Among all these, the most important is HPV infection. Among all these, most important is HPV infection. Right? Okay, so this is an image based. This is an image based. What are these? What is this and what is this? So first tell me what is this picture? That's the iris spatula. That's the iris spatula. Right? So iris spatula helps you to take the smear from the ectocervix. In the pap smear, iris spatula helps you to take the smear from ectocervix. The next one which you have is cytobreast. Cytobreast will take the smear from the endocervix. Cytobreast will take the smear from endocervix. So this iris spatula and cytobreast, this iris spatula and cytobreast are used for pap smear. Whereas this one which you have is the this is called as Rover's endocervical cytobreast. This is called Rover's endocervical cytobreast. Okay. So where do we use this Rover's endocervical cytobreast? This Rover's endocervical cytobreast is used for liquid-based cytology. Now you have some tests better than pap smear. Earlier it was like only pap smear you were telling. But now we have better tests than pap smear, that is the liquid-based cytology. In liquid-based cytology, you don't require like two things. We just have only this cytobreast, and this part will go into the endocervix, and this part will go into the ectocervix. And then you take a 360-degree smear. Okay. Let's understand the difference between these two investigations also. Okay. Something similar to this question has come in the INI CET, right? So actually, many of us have a feeling that pap smear is only for diagnosing the cancers. But pap smear is not just only for diagnosing the cancer. You can also diagnose the infections. So pap smear is useful in diagnosing all of the following except gonorrhea, trichomonas, HPV, inflammatory changes. So what will be the answer for this? So basic knowledge which we have is pap smear is used for malignancy detection. You can detect the malignancy. You can detect the malignancies like, cervical cancer, vulval cancer, right? But apart from that, you can also detect infections. You can detect Trichomonas vaginalis. You can detect HPV, so obviously you can detect, right? And you can also detect inflammatory changes. Gonorrhea is intracellular and less likely to be seen. So this is the next image. What is this? So this which is angulated and it has a jaw, teeth and jaw. What is this? This is a punch biopsy needle. This is a punch biopsy needle on the cervix, where whenever you have a visible lesions on the cervix, you can take a punch biopsy. Whenever you have visible lesions on the cervix, you can take a punch biopsy. Okay. And all of the following are indications of colposcopy. So when all do you do colposcopy? So screening methods may, now if I have to speak little precise, let me tell you a few points. Screening methods may, you have pap smear, you have pap smear, you have LBC, you have HPV DNA testing, you have VIA and VILI. You have VIA and VILI. Okay. In these, HPV DNA test is the best screening method with highest detection rate. Screening method of choice in low resource setting is VIA. Screening method of choice in low resource setting is VIA. Screening method of choice in low resource setting is VIA, visual inspection under Lugol's iodine. Why? Because it is very easy to perform and even a midwife can also understand whether it's a normal cervix or abnormal cervix and treat accordingly. So when you put acetic acid and if you see a white patch, or an abnormal patch, you can take a biopsy and send to the higher center. So that little training we can give to the midwife or ASHA worker, and so you can give to a local people, and once so they themselves can diagnose this abnormal cervix and they can send the abnormal cervix to the for higher centers. So that way the cervical cancers, CINs, are easily picked up. We do practice in India many camps where we go to the rural areas and put a camp and gather all the women of the village for the VIA. And whatever abnormal cervix we feel, white patch or anything, we just take that biopsy and take to the lab. And many times we pick up so many cancers like cancers in CIN2 stage. We can pick up CIN2s. We have picked up early cancers. So that way you are giving a better treatment and you're downgrading the cervical cancer in India. You're downgrading the cervical cancer in India, right? So VIA, you put acetic acid on the cervix and visualize the cervix. If you have unstained cervix, it is normal. And if you have white patch, then it is a cancer. Then it is a cancer. Okay. Now coming to the pap smear. Pap smear, you have iris patula and cytobreast. Both of them you take the smear and you put it on the slide. After you put it on the slide, you put it in the specimen in the Copeland jar where the specimen is 95% ethyl alcohol. And then you send for papinicular staining. And then you will examine it. Then you will air dry it and examine it. Do you know in this entire process, take a smear, put it on the slide, then put it in the specimen, to stain it, then dry it, you lose 80% of the cells. So the detection rate of pap smear is bad, and they always have the problem of sample inadequacy. To replace that, we have got this liquid-based cytology. LBC or liquid-based cytology may this cytobreast, you take the smear, you don't put it on any slide, you break this and then directly you put it in the specimen. Here the specimen is methanol. You send it to the lab and then this specimen should be centrifuged. Then it should be centrifuged. On centrifuging, you get a single layer of all the cells. Single layer of all cervical cells, where you can detect the abnormality. So sample adequacy is more, detection rate of cancer is more, and this same sample can be used for diagnosing, can be used for HPV DNA testing also. Okay, so those are the screening methods. Whenever any of these screening methods are abnormal, what will be your next step you will do? The next step is going for a confirmatory test. The confirmatory test is colposcopy. The confirmatory test is colposcopy. If you have a visible lesion, directly go for punch biopsy. But if you have a microscopic lesion or invisible lesion, you will go for colposcopy. So all of the following are indications of colposcopy. So which all your answers are correct for this statement, for this question? Yes. So whenever you have a suspicious pap smear, you will go for colposcopy. This is something very much you have to remember, whenever you have a suspicious pap smear, you never, and whenever you have an abnormal pap smear, you will never treat her based on pap smear. You will always go for confirmation with colposcopy. So option A is correct, and obvious mass seen, you will not go for colposcopy. Suspected invasive cancer, yes, you will go for colposcopy. So A and C are correct options. A and C are correct options, right? Next, a 45-year-old woman has negative pap smear but positive endocervical curettage. Next step in the management will be colposcopy, vaginal hysterectomy, conization, Werthin's hysterectomy. Excellent, excellent, Bhargavi. So the answer for this will be conization. So why? Let's understand that also. So when you have a negative pap smear, iska matlab pap smear is not abnormal. Pap smear is not abnormal means it is not a lesion of ectocervix. Not a lesion of ectocervix. So when you have a lesion of ectocervix, you can do colposcopy. By colposcopy, your magnification will be 2x to 40x. But how much ever you magnify, you will be able to see the ectocervix and transformation zone and very little of endocervix. Upper two-thirds of endocervix you can't visualize on colposcopy. When there is a positive endocervical curettage, it means that there is problem in the endocervix. There is a problem in the endocervix. To visualize, whenever you have a problem in the endocervix, you should go for conization. You should go for conization. Okay. So what are the indications of conization is also a very, very, very important point. So there are both diagnostic as well as therapeutic indications of conization. There are both diagnostic as well as therapeutic indications of conization. Diagnostic indications is when the limits of the lesions are not seen, when transformation zone is not seen on colposcopy. When transformation zone is not seen on colposcopy, you have to do cone biopsy. When you have endocervical curettage positive, when there is no correlation, lack of correlation between colposcopy and pap smear results. And when pap smear is suspecting, pap smear shows adenocarcinoma in situ or carcinoma in situ, right? Therapeutic indication, microinvasive cancers, young female with microinvasive cancer, that is stage 1A1, and carcinoma in situ. You can go for conization. So these are the therapeutic and diagnostic indications of conization, which is very important. Next question. Pap smear of Leelavati, 45-year-old, shows grade 3, CIN grade 3. Which of the following is the next step in the management? Punch biopsy, large loop excision, colposcopy directed biopsy, cone biopsy. Yes, what is the answer for this you're thinking? So very important, based on pap smear, you will never treat them. So based on pap smear, you will never treat them. So on pap smear, it is showing CIN grade 3. So what should be your next step? So based on pap smear, you will not treat them, right? If you have thought you're like large loop excision or something like that, it's absolutely wrong. Because based on pap smear, you should not treat. So as pap smear is a screening test, you have to confirm it. And what is the management you're going to do for confirming it? So for confirming it, you will go for colposcopic directed biopsy. For confirming it, you will go for colposcopic directed biopsy. Right? So the best answer here you have is C. The best answer you have here is C. Now let's see what should be the treatment for CINs. CIN1, the treatment is CIN1, the treatment is you can just follow her up for 2 years. And if abnormalities persist for 2 years, then you go for either ablative procedure or LEAP. You follow her up for 2 years, and if abnormalities persist beyond 2 years, go for ablative procedure or LEAP. If you're having CIN2, you either go for ablative procedure or LEAP. If you are going for CIN3, then LEAP at any age group. Then you have to do LEAP at any age group. If you have recurrent CIN3, then it is hysterectomy. If you have recurrent CIN3, then it is hysterectomy. CIN extending to vaginal fornices, laser ablation or hysterectomy. Very, 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 very important point here is if CIN3 is there at any age group, the management is LEAP itself. For CIN3, at any age group, it is LEAP itself. That's a very, very, very important point. And it has come as an exam question also. So if somebody asks you 60 years old, has CIN3, what is your management? Most of them go for hysterectomy. That is wrong. CIN3 is the management is LEAP at any age group. Okay. So what does these ablative procedures means and what does LEAP means? So in ablative procedures, you have cryotherapy and you have laser ablation. So this is a cryotherapy probe. So this is a cylinder which will have the compressed nitrogen gas, and this is a cryo probe by which you're going to release the compressed nitrogen gas or compressed, carbon dioxide, and that will cause crystallization of this cervix. Okay, and it will burn the cervix. Laser ablation also you can use. Laser ablation also you can use. Laser ablation mein you use laser to burn the cervical epithelial cells. So there you are using heat for burning the cervical epithelial cells. Here you are using cold, extreme of temperature, cold to burn the cervical epithelial cells. This is large loop excision of transformation zone, which is excisional procedure. The advantage of large loop excision of transformation zone is you're slicing the cervix. So you have the tissue to confirm your diagnosis. You have the tissue to confirm your diagnosis. Okay. So this is a small loop which has both cutting and coagulation. So they don't bleed. It will cut and it will coagulate. It will cut and coagulate. So you're going to slice the cervix like an apple slicer, peeler ke jaise. Okay. And all this can be done under mild sedation. You don't require the proper anesthesia or something like that, right? So that's another beauty. But another few important points regarding these ablative procedures are cryotherapy. It is an ablative procedure. You use liquid nitrous oxide or carbon dioxide at -20 to -30 degrees Celsius. The depth of destruction, the depth of destruction of the cervix here is 5 mm. The depth of destruction of the cervix here is 5 mm. Okay. Right. Next is another ablative procedure here is laser ablation. Laser ablation mein you will take CO2 laser. Here you use heat to coagulate to destroy the cervical cells. The depth of destruction is 7 mm. This laser ablation is mainly used when there is an extension to vaginal fornices. It is of main benefit when there is extension to vaginal fornices. Next, you have excisional procedure. Excisional procedure में you have large loop excision of transformation zone. Large loop excision of transformation zone. Large loop excision of transformation zone में you're using a electrocoagulating cutting and coagulating tip. Here the depth of destruction is 10 mm. It is the management of choice for any patients with CIN3 at any age group. Okay. What are the limitations of these procedures are? These procedures cannot be used for endocervical lesions. None of these three. You cannot use them for endocervical lesions. You cannot use them for carcinoma in situ. And you cannot use them for recurrent CINs. Okay. So you can use them only for ectocervical lesions. You can use them only for ectocervical lesions. So that is about the management of CIN. So today we saw mainly CIN and germ cell ovarian tumors. So CIN1, if abnormalities persist for 2 years, go for ablative procedure or LEAP. CIN2, ablative procedure or LEAP. CIN3, LEAP. Recurrent CIN3, hysterectomy. CIN extending to vaginal fornices, laser ablation or hysterectomy. Which of the following statement about squamous cell carcinoma of the cervix is false? Common at squamocolumnar junction. CT scan is not used for staging. Postcoital bleeding is common symptom. HPV 18 and 16 are high risk for carcinogenesis. To be frank, I don't agree with two statements here, but most strong statement is B, because CT scan can be used for staging nowadays. And postcoital bleeding is not a common symptom, but a specific symptom. It's a specific symptom, right? So it is common at squamocolumnar junction is absolutely correct. You can use CT scan for staging. HPV 18 and 16 are associated with high risk of carcinogenesis is also a correct statement. So B is a wrong. So revised staging allows. You have revised guidelines of FIGO staging in 2018, right? So revised FIGO staging in 2018 has released many procedures. You can do any of these procedures. You can do CT scan, you can do MRI, you can do PET scan, you can do USG, you can do pathological lymph node examination. You do whatever you want, but you have to diagnose it appropriately. So you can use any of them, but you have to diagnose it appropriately, right? Okay. So I think we will stop here. We will discuss some more MCQs tomorrow, and I'll be again coming back at 7 p.m. only tomorrow. So tomorrow I am planning to do more of, image-based session, complete images, like a revision series of images. As your exam is near, so I'll be going on showing you different images starting from OBG. So we will be doing mainly OBG images tomorrow, all images compiled at one place, and I'll be showing them. Okay. Thank you guys. All the best. Keep studying. Any queries you can always ask. Right. And one more thing, here we told postcoital bleeding is a specific symptom, not a common symptom. So you should also be aware that CS cervix has 4 cardinal signs and 4 cardinal symptoms. CS cervix has 4 cardinal signs and 4 cardinal symptoms. The 4 cardinal signs are irregular bleeding, postcoital bleeding, foul smelling discharge, and pelvic pain. Four cardinal symptoms, these are all 4 cardinal symptoms. The 4 cardinal signs are, it is a cauliflower-like growth, okay? So it is hard and indurated. It is fixed. It is cauliflower-like growth and which is friable. So it tukde nikal sakte hai. And it bleeds on touch. It bleeds on touch. So these are 4 cardinal signs. So the 4 cardinal signs for CS cervix are hard indurated, fixed, bleeds on touch, and friable. 4 cardinal symptoms are irregular bleeding, postcoital bleeding, foul smelling discharge, and pelvic pain. It smells like ganji, the rice boiled water. Okay. And the complications of CS cervix are, it's like a quick revision of CS cervix, I'm telling. The complications of CS cervix, you can remember it as puff, pyometra, uremia, and fistulas. The most common cause of death is uremia. The most common cause of death in CS cervix is uremia. It has bimodal peak. The first peak is around 35 to 39 years. The second peak is between 60 to 65 years. The most common type of CS cervix is squamous cell carcinoma, that too large cell keratinizing type. Large cell keratinizing type squamous cell carcinoma. And the mode of spread is through lymphatics. The mode of spread is lymphatics. It is clinically staged, but the revised guidelines tell you can also, it is clinically staged, but revised guidelines tells you can also use investigation for staging the CS cervix. Management may, I'll tell you very simple funda for remembering the management. Okay. Management, just a quick revision. Okay. Staging starts from stage 1A1. Right. Keep A1 constant. 1 के बाद what is the next number which we get? 2. So management from 1A1 to 2A1 is surgical management. Surgical management. So basically you're going to do hysterectomy and lymph node dissection. And please remember another thing. In surgical management of CS cervix, you never remove ovary. Ovary is spared. Ovary is spared. And this 1A1 to 2A1 except 1B3. Whenever you have size of the tumor more than 4 centimeters, you cannot, it has a bad prognosis and you can't do surgical management. So obviously the rest of the stages, that is 2A2 to 4 and 1B3, you're going to do concurrent chemoradiotherapy. That is, you give cisplatin followed by brachytherapy, interstitial brachytherapy, where you have point A and point B. So you insert the tandem and ovoids inside the uterus, right? So you have point A and point B. Point A is 2 centimeters above and 2 centimeters lateral to external os. 2 centimeters above and 2 centimeters lateral to external os. Point A, you are targeting mainly paracervical lymph nodes. And towards the point A, you have to give 80 gray radiation. Point B is 3 centimeters lateral to point A. Point B targets towards obturator lymph nodes. You give 60 gray radiation. These are the most important points pertaining to your CS cervix. You know this much, more than enough, right? And another important is, in young women, what can be the sparing surgery? Like, you know, what are the uterine preserving surgeries you can do? For a young female with CS cervix, stage 1A1, go for conization. 1A2 to 2A1, you do radical trachelectomy, where you you amputate the cervix till you have a cancer-free margin. You amputate the cervix till it has a cancer-free margin, and then you tie it off. Then you put a stitch. Then you put a stitch. And you also do lymph node dissection, plus lymph node dissection. So in future, the mode of delivery for her will be by cesarean section. Lymphadenectomy also you'll do. So in future, the mode of delivery for her will be cesarean section. Again, this is except 1B3, except 1B3. Simple. How can you prevent cervical cancer? The last point is prevention. Prevention में outdated vaccines are Cervarix. Cervarix to gone. Gardasil, which is against 4 HPVs, is also not much used. What we use nowadays is Gardasil 9. What we use nowadays is Gardasil 9. And how do you prepare the Gardasil 9 vaccine is, it contains the purified inactive forms of this Gardasil 9 contains the virus-like proteins. Virus-like proteins, that is L1 capsid protein of HPV, 9 HPVs, HPV 6, 11, 16, 18, 31, 33, 45, 52, 58. You have to give this for both male and female. This is given both male and female. Actually, this is included in the vaccination schedule for Americans, but in India, we don't include in the vaccination schedule. But what you should be knowing is, If you are giving for between 9 to 14 years age group, it is 2 doses, 0 and between 6 to 12 months. It's an IM injection in the deltoid. Okay. And when you're giving it to those from between 14 years, above 14 years to 26 years, it is 3 doses, 0, 1 to 2 months, and 6 months. FDA has now approved it. FDA has approved it now till 45 years. So you can give patients between 27 to 45 years also. You can give it now between 27 to 45 years also. Okay. And this protects against many cancers, not only just about the cervical cancer. So it protects pre-malignant and malignant lesions of vulva, vagina, cervix, and anal. It protects against pre-malignant and malignant lesions of vulva, vagina, cervix, anal. Some books also give oral cancers. Okay, so that's about all. Those are all the important points pertaining to CA cervix. If you realize, I have discussed the entire CA cervix in a crisp manner for you to revise in your exam. So whenever you want, you can again go through what I have told in the last 10 to 15 minutes. We finished the CA cervix. If you know that much pertaining to CA cervix, super, you will 100% able to answer all the questions pertaining to CA cervix. CA cervix is a very, very, very important topic, and please go through vulval cancer also, as you got a question on vulval cancer in the mid exams of FMGE. Okay, so thank you. All the best. Keep studying. I'll see you again tomorrow at 7 p.m. Thank you, guys.